Professor Mark Gilchrist from the UK will be sharing his experience from the UK point of view. So Mark is a consultant pharmacist, infectious disease specialist at the Imperial College Healthcare NHS Trust in the UK. He has a special interest in infectious diseases and antimicrobial stewardship and he is a council member of the British Society of Antimicrobial Chemotherapy and has been leading the UK OPAT initiative in this capacity. Mark has a specific interest in antimicrobial stewardship and in improving systems and processes that affect local, national, and international AMR programs.
Thanks, Fakari, and amazing talks by David and Afra. I think amazing work that you're doing. So thanks so much for sharing that. So thank you very much for the organizers for the invitation. It's always a pleasure to talk to friends on the other side of the world and share experiences. I'm going to take a slightly different tact and try and present the national perspective of where OPAT is in the UK and just turn our kind of clocks back a little bit to how I think David wins in 1980s. We were 1992 when we started OPAT. So we're kind of celebrating around 30 years of OPAT within the United Kingdom. It first started in Oxford, as some of you may know, by two folk, in particular district nursing led and experiences from sort of primary care community type background. It then led on to a research sort of letter documenting experiences out of Leicester around 1995. And then there was some Scottish experience in the late 90s from the Dundee Nine Wells group there. And really this was about, infection enthusiasts sending patients home for common conditions driven by infectious diseases. There was no sort of funding involved in this. And it was a kind of nice to have model. There were surveys that were done in the late 1990s with UK and Ireland that showed that OPAT was on the rise. This was when emails weren't in use. So this was all handwritten envelopes, paper pigeons type, getting surveys back. And then back in 2017, there was an email survey that was done that was sent around to 178 hospitals within the UK. So we then moved on to the sort of 2015 era, and this was the first time that we'd actually looked at OPAT services that were in existence. So across the 4 nations of the UK, there were 57 OPAT services that submitted to the National Outcomes Registry. The reference is on the bottom right-hand side of your screen, but it details the condition seen, the antibiotic seen, and for the first time detailing and profiling OPAT services, over 27,000 patient episodes and mean durations of therapy of patients on the OPAT service. But we know that was a fraction. We know there were about 90 services registered through the BSAC OPAT directory, and we know that we can do more. Following on from that, the NORS data generated within the United Kingdom, anyway, a clinical and a clinical effectiveness economic analysis that was done by Health Improvement Scotland. They took our data commissioned by BSAC and commissioned by the Scottish Antimicrobial Prescribing Group, really to evaluate OPAT with some clear messages for the other countries within the United Kingdom. And this was around equality, making sure people could access OPAT where they needed to, specifically in Scotland. And the Scottish government gave money for hospital in the home or virtual ward systems within Scotland. And those recommendations, as I say, have been shared with other devolved administrations. So we're slightly moving from a nice to have to a must have service within the United Kingdom in terms of OPAT services. But if we look at where we are in England, there are still gaps within OPAT provision. So this is about equality and ability to access services within the United Kingdom. So 165 trusts or hospitals were asked. Do they have an OPAT service? Is it continuing? We got 116 back, and we identified that the southwest, the north, and east still don't have reliable OPAT services in which to offer that to patients. So we've got an inequality balance within services across England. And so with that, from a UK perspective and models of care, we've tried to address this, and it's slightly frustrating for those of us who've been in the business for quite a while, but we've tried to manage this, a new argument around the strategic case, the economic, financial, and management case, because if we start to understand in the heads of our managers, as much as it's frustrating, we can try and make sure that the equality angle and access to patients is there. So certainly the strategic case is there. We've got a third of inpatients at any one time on antimicrobials, of which 50% of those are intravenous. COVID has certainly helped manage the OPAT agenda. It's been very much at the forefront in terms of the response, keeping people at home and managing infections at home and not in a hospital environment, but also part of that recovery as well. And that's been also linked to a decline in capacity. On the right-hand side, you'll see the number of beds that we have open. This is from sort of government figures, both in a total perspective and an acute in general. It's going down every year, and it's had a slight rise post-COVID, but we have a declining capacity. That impacts on patient flow in our organizations. And so we're having to really reevaluate and provide opportunities for OPAT and health in the home in terms of patient flow. And we need to do things differently. It needs to be patient-centered. There needs to be care closer to home, and that equitable care, which is probably more important than it's ever been. If you look at all emergency admissions within hospital in the United Kingdom, all admissions are going up. But if you look at bacterial infection through admissions, they're going up, and we could argue at a steeper rate than all admissions. And this is important because, in a way, we've kind of given the public or the population an increase in knowledge around infection, and we need to really harness that. So if they're thinking about infection, staff are thinking about infection, probably all due to COVID. We can harness that and harness the OPAT agenda. If you look at the top 10 attendance rates to emergency departments in the United Kingdom, 7 out of those 10 are infection related. And whilst UTI is at the top, the respiratory, if you group all the respiratory conditions together, they are by far the biggest attendance for emergency admissions with cellulitis there. So a big grouping for infections. And again, if you look at those that are admitted through the sort of 3 big diagnostic categories that I spoke about, you see it's an awful lot. These are big numbers. There are a lot of patients that are being seen. There are a lot of patients that are being admitted, but also a lot that are attending. So there's an opportunity there for admission avoidance. And like David, I don't really like that phrase, but it is there. Why is that? Well, there's an increasing growth of living longer. Within the United Kingdom anyway, and elsewhere, we've got about 4% of the population are classified as immunocompromised. There are more complex immunosuppressive therapies, and there's an increase in keeping people alive. If you look at that, the article that's on the screen, really lovely 36-year period, overall standardized mortality. Look at the 2 numbers. We are treating people and keeping people alive for longer, so that it is harder for us. Within secondary care, our challenges are really around the fact that we are not funded for some of this activity, and that if you think about our business managers, they always look at finance, they look at budget, they look at lack of flow. So we've lost that sort of primary care filter for moving flow up and down. We're losing our 4-hour waits for those that keep in the news, and we've also got hospital in the home, sort of keeping people out of the hospital. There's a human resource angle to that, and also there's the COVID and recovery has been in there. And as I've described, we've got a complex need, immunosuppression and complex infections and AMR. However, from an OPAT perspective and models of care, that provides us a really clear opportunity. How can we as infection specialists identify these patients early, look for microbiology techniques, maximize IV to oral, adapt our OPAT dynamics and patient needs, and also use better resource, both in terms of nursing time and opportunity costs. So there's a real service delivery perspective on this, but actually I think quite an opportunity for infection in the UK and OPAT services. From a drugs perspective and treatment perspective, there are still gaps in the availability of the right drug and right timings for these. So we've got complex orals coming on, we've got longer acting IVs, shorter durations, hitting that antimicrobial stewardship perspective. And on the right-hand side, just a few things that keep OPAT alive, you could say, rather than complex orals. So, continuous infusions for things like endocarditis, temacillin, which is certainly up and coming in Europe, and thoughts about that within other market areas, the gram-negative agents and threats of that. And from that bears really lovely partnerships. And this is just a slight plug and for humoring me and others in the room. But when we work together to look at OPAT as a wider perspective, we work together for benefit for the patients. And so there's some lovely collaborative work between colleagues in Australia and the UK about trying to push those boundaries and think about new ways of delivering drugs to patients. And so if you want to know more about that, there's more on the website at the bottom of the page. But it's really important. It's not just about the drivers. From a financial perspective, it's clinical evaluation. So the next thing that from a model of care that we're really reevaluating, and this is to make OPAT a must-have within our clinical environment, not a nice-to-have. Clinical activity is a measurement and visualization is really critical, and we are not good at doing this within the UK, which is hampering on our delineation between different models of care that we see. We've got patients on service, we've got inpatient days avoided, that's great, but what does it mean? What does admission avoidance mean in kind of short-term duration and the pressures at the front door? And then we've got a term which I like more, which is supported discharge. So how do we get people out of hospital? How do we align surgical and medical specialties? And how do we create that capacity within acute, continuing, and cancer care, the places that sort of need it? And just to sort of illustrate the point, this was an email I got 2 days ago. I don't expect you to read the talk, but it's a service crying out for the fact that their OPAT service has been axed. They need to write new business cases, and it's really affecting the models of therapy that we're seeing within the UK. So this is a very real problem that we're seeing up and down the country, and that is to do with lack of uniformity of data, as I've said, the lack of clinical activity, and how we record this and how we feed that up to government level, and so that it's funded, and that all clinical episodes that we action are recorded and promoted. So these slides now are from Andrew Seaton, a great friend and colleague of mine in Scotland, because Scotland are really leading the way, and this is why I want to give you this UK approach in terms of how to visualize this sort of data. They have been collecting data on a weekly basis from their health board since January, almost 2 years now, around daily referrals new to service, those at admission avoidance, which almost looks at virtual capacity, those that are coming on service and their medium length of stay. It's a really simple template, and I'll show you how you can get hold of this in a minute, because it really has started to change the mindsets of certainly in Scotland and then over to the other countries. But if you look at, this is data from Scotland about new patients coming onto OPAT and then discharges. The red line here is the where funding was introduced. I mentioned that funding was granted by the Scottish government to promote virtual, more health in the home type environments. That allowed greater funding, greater staffing, and with that greater staffing, you see in all health boards in Scotland, apart from two, you see that rise in patients being accepted. And that has meant around about a 34% admission avoidance of new patients not coming into hospital and just being managed through OPAT. And if we estimate estimate the cases, sort of 90 to 100 cases per 100 population, certainly within the UK. In Northern Ireland, it goes up to about 1900. In Wales, it goes up to around 3100, and England, 56,000. And if you add all those together, we're looking within the UK with different models of care deployed, over 1 million inpatient days avoided through OPAT services if we were to fund them correctly. So that's a really powerful message. The financial case is obviously there. We have looked within the UK of bringing some top 6, 7 diagnostic categories identified through the National Outcomes Registry and also other surveys that have been done. It's not exhaustive, and I grant you, it's not some of the more complex things we see in the OPAT environment, but certainly we were able to model these, and I'll go on to tell you about that in a second. But our models of care vary between resource and settings, and the ones on the screen are probably familiar to most people within the OPAT settings. But this is important because we modeled the diagnostic categories I showed you in the previous slide with these modalities of care that you're seeing here, and we calculated the cost impact that would be in UK hospitals. So for more detail, the publications is on the screen there. But if you think of a complete inpatient basis being 100% of the cost, daily OPAT, home visits, self-administration, and even the use of longer acting drugs significantly decreases the cost of giving models of care through the OPAT mechanism. So 25, 34, 25, 50% reductions in as part of that costing. And then if you look at, say, we just take bone and joint infections, for example, again, that cost is decreased, particularly if you put in the COPAT, so you put in the complex orals in that, either elastomerics, bolusing, home administration, or daily visits. So there's a significant cost saving to that, but it needs to be made clear. If anyone wants to download the cost calculator, you can do it. It's not a UK-centric thing. You can download the OPAT calculator, and you can fill in yourself what you think your proportion is per service, what that equates to in models of care. It gives you the standardization behind the scenes, and that gives you a projected cost saving. You can also user define on the right-hand side here your durations of therapy to help you tweak your results. So it's a really nice way. I know everyone sort of hates cost calculators and wants to know what's behind the scenes, but it's all open access. You can't change it, but you can see where we've got the data from anyway. So it's a useful tool, but that gives you the sort of financial side of it. And then we're still promoting from a national perspective the good practice recommendations, and the clinical governance structures, contingency plans, what we expect from a QI perspective. And this is very much from models of care run in terms of multidisciplinary. It involves pharmacy staff, specialist nursing, medical staff together, working together. And these good practice recommendations are currently under review. They're going to be revised and published for adults and pediatrics. And the hope is that we're able to demonstrate how many medical, nursing, and pharmacy staff you need per 100 patients on OPAT as well, to give people that infrastructure. We need to look at patients that are referred and look at their vetting outcomes. That's really important, the vetting outcomes in terms of, can you put people to oral before they even hit the OPAT radar? Those that are entering the service, outcome measures that you would expect, and the OPAT UK good practice recommendations outcomes are on the screen, and we've changed those to what is your treatment intent rather than hard and fast outcome measures, and particularly in the palliative region. Some case vignettes just to finish on. We are reviewing our models of care. This is again friends in Inverness in Scotland. So if you're ever on your travels and you're coming to the north of the country, we have OPAT services. In red, there are the main hospitals. In blue are the satellites, and it's really a hub and spoke type model. We're ensuring good governance, and we're ensuring access to care, and we're ensuring that the leadership and the support are there from the main hubs. So that's in keeping with other countries that have got long distances for patients to travel. The other thing that we are getting to grips with is this virtual ward concept that's coming in to the UK and how that affects OPAT services. It's as has been described, it's sort of requiring daily input from multidisciplinary teams, but it allows people to sit virtually outside of the hospital, but with a supportive care network around them. And they provide sort of urgent access to hospital level diagnostics and things, point of care tests, hospital interventions, but without actually being in a hospital bed physically on site. And that ticks lots of boxes around demand and access, engaging patients in co-production of our services, particularly from an OPAT perspective, harnessing partnerships, leadership, and workforce, and making sure we are managing that clinical risk in all of that by having the teams together. But there has to be good governance around that. And so very much we're integrating virtual wards as a single point of access, but within an OPAT dynamic. So a little bit of what David said, and I'm pleased to see that sort of we're traveling at the same trajectory on that. But OPAT really forms that remote monitoring as part of hospital in the home, as part of a wider package of care. There are absolutely things that health in the home is not, and equally things that OPAT is not. But we have to really think about that. In terms of other considerations in our models and how we're changing them, there's an increase in telemedicine, both for non-infection specialists and infection specialists. We've got an increase in our data for oral anti-infectives that we're seeing. Equity of access is really important, particularly for care models like intravenous drug users, people who have got deprivation around, who find it difficult to access care. And it's an important model that we're looking at, whether that's outreach services and how you engage those services and how you piggyback them onto others. Longer acting agents and the need for therapeutic drug monitoring is important. And we have to think about that in our models of care. So really just to bring this all together, the COVID pandemic's highlighted the need that we need to think and do things differently with our populations from an OPAT perspective and those models of care. We do have huge opportunities, particularly around the supported discharge area. And we've got an inpatient resource that is not infinite. We need to optimize it. We need to be efficient. We need to look at how we can deliver all of this care in the community and allow that capacity for acute, elective, and cancer care within our organizations itself. You know, infection is one of the common reasons in the UK for hospital admissions. They are complicated, particularly by surgical intervention. And as I said, over about 30 to 40% of patients are receiving antimicrobials at any one time. The good thing is that the government's recognised OPAT as a national push. It's part of most of the stewardship drivers. But unfortunately, that's not well known in people who sit outside of infection. And so we need to change what we're doing, and we need to look at the complex growth in populations and what infections are likely to come as a result of those immunosuppressive medications that I've spoken about. We have to engage UK healthcare. That's kind of where we are, because it will change the models of care. We've got a health and well-being gap. We've got a care and quality gap. We've got a funding gap, and we need to make sure those in the sort of blue boxes in the center are really pushed. So there is local ownership. We have local workshops and seminars up and down the country for OPAT. But we have national support, and we've managed to change the government view, particularly in Scotland, and we're in very much active discussions with the English sort of system as well, but putting patients at the heart of that. But it has to be financial, it has to be targeted, and it has to have data integrity behind the whole thing. So my final sort of words are that we need to modernize this definition of OPAT really within the UK and abroad. I would say we need to work with peer organizations to make that happen. And we need to include something around supervision of complex oral medicines in the non-inpatient setting. And I don't think our terminology has been helpful. I think it's clunky. And I think that we need to make sure we have better structures in place, particularly to articulate that to patients, because as I said at the beginning, we have kind of weaponized the population around infection pretty much due to COVID, and there's an appetite there in which they are engaged, and we need to we need to harness that. So thank you very much to everyone involved. I'm lucky to speak, but there's a huge amount of people behind the scenes, pictures and friends from across the world as well. So thank you very much for your time and attention.
Yeah, thank you, Mark, for another very inspiring talk.